Welcome everybody to the emerging role of circulating tumor DNA in GIST. During this seminar, all participants will be in a listen-only mode. There will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. Please remember the information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild. I'm the Executive Director of the LifeRaft Group. We would like to thank Genentech, Blueprint, Decipher, and Novartis for their educational grants for today's webinar. And now I'd like to introduce our speakers. Dr. Steve Bialick is a second-year Hematology Oncology Fellow at Jackson Memorial Hospital and the University of Miami Sylvester Comprehensive Cancer Center in Miami, Florida. He completed his internal medicine residency within the University of Pennsylvania Health System before working as a hematologic malignancy hospitalist at the Hospital of the University of Pennsylvania in Philadelphia. He is now completing his oncology training with a focus on solid tumor malignancies, specifically soft tissue and bone sarcomas. His research interests include hereditary cancer predisposition syndromes, circulating tumor DNA, and his role in guiding targeted therapies, and the role of DNA damage repair pathways in sarcomas. And some of you may recognize Dr. Bialick from previous webinars, so we're very excited to have him back today. In addition, Stacey Stevens, she is a caregiver and advocate for her husband, Fate, and she will provide a testimonial in regards to receiving this type of diagnostic care after Dr. Bialick's presentation. So for now, I'm going to hand this over to Dr. Bialick to begin.
Thank you so much. Thank you for the introduction. And it's awesome to be here with LifeRaft again and with Ms. Stevens. This is an honor for me to present, and I'm happy to join you guys and thank everybody for tuning in on this, well, here in Florida, lovely Wednesday. I don't know where you guys are. Since the last time I presented, Sarah, with LifeRaft, now I'm a third-year fellow graduating in just a couple months. So it is an exciting time.
Congratulations. I thought maybe the year was off.
No, it's tricky, but yes. Can you see my screen okay? The slides that I'm...
Yes, I do. The slides look good.
Perfect. So you see, okay, awesome. So like we said, we're going to talk today about the emerging role of circulating tumor DNA in GIST. And we'll kind of go through, oh, I guess the slide tells you that I have no disclosures. And when we go through the presentation at the end, I think there'll be some time for questions, but jot them down if you forget them or so you don't forget them. But what we'll do is start broad and kind of narrow it into the meat and potatoes of the talk, a little bit of background about sarcoma in general, and then we'll hone it in and talk more specifically about GIST, which is why I think we're all here and excited about chatting together. We'll talk about what we call conventional molecular profiling, and then focus on circulating tumor DNA or ctDNA and its utility in gastrointestinal stromal tumors. And then at the end, we'll touch on two different abstracts that were presented most recently at ASCO, the American Society of Clinical Oncology, this past June in Chicago, where all the oncologists get together annually to talk about new and exciting data that we have. So we'll talk about the resistance mutations and how they're relevant in patients with GIST. So as we know, sarcoma is a rare cancer. It actually affects less than 1% of adults and 15% of children. And when I say here that it comes with this widespread biologic variety, meaning there's over 175 different kinds of sarcoma. So unlike breast cancer or colon cancer or lung cancer, which are cancers named from the organ that they start in, sarcoma is actually a cancer of connective tissue. So this little guy, this figure on the right, shows us all the different areas in our body where we have connective tissue, and any of these tissues can turn into a malignancy or a cancer, whether that's nerves, fat, muscles, blood vessels, anything that connects one tissue to another has the propensity to become cancer, and that is called sarcoma. And so because there are so many different kinds of sarcoma, we as scientists and physicians are always looking for different research topics and areas so that we can better understand the genetic makeup, the genetic landscape of these sarcomas, so that we can find treatments that have the possibility of being more effective and potentially less toxic, less side effects. And we use a mechanism called precision oncology, which if you say that 5 times fast, as I've given this talk many times, it's very hard to do. precision oncology. And that is the term that basically tells us how we find the molecular makeup and detecting these different molecular changes in the cancer so that we can target them with medicine. So in the United States, I mentioned that breast cancer is a cancer of the breast tissue, and it's way more common than sarcoma. Sarcoma, again, making up only 1% of all adult cancers. In the year 2022, probably 260-ish thousand people will be diagnosed with breast cancer in the United States, but only about 13,000 will be diagnosed with any type of sarcoma. And because of the way treatment is with sarcoma, unfortunately, about 5,000 people will pass away with sarcoma this year. And so it requires us to have a multidisciplinary treatment approach. Multidisciplinary meaning surgeons need to be involved, radiation oncologists, medical oncologists like myself who give medicine like chemotherapy and targeted therapy. So this slide is very busy, and it shows us that these sarcomas have distinct clinical features and pathologic features. Pathologic means that someone's looking at the microscope, looking at the cells, and they call these sarcoma subtypes what they are based on the cell that they are originate from. And the problem in our sarcoma world is that not all pathologists agree on what those cells look like. And it's important, patients with a diagnosis of sarcoma get seen or treated at what we call tertiary sarcoma centers that have advanced sarcoma pathologists to find that diagnosis. Since there's so many, I actually couldn't even fit them all on this slide, but the important one, again, the one that we're all here to talk about today is the gastrointestinal stromal tumor, or GIST for short. So GIST is the most common sarcoma of the gut tract. When we look at all gastrointestinal malignancies, which includes anything all the way from the mouth to the anus, the entire gut tract, including esophageal cancers, colon cancers, pancreas cancers, GIST, or gastrointestinal stromal tumor, makes up 1 to 2% of all gastrointestinal malignancies. Stomach or gastric cancer is one of them. But the GIST tumors arise not from cells that line the stomach called or the gastric cells, but they're actually connective tissue cells that are in charge of making the gut tract squeeze to help food get digested and pass through the stool. Those cells that are in charge of making that peristalsis, the word for contractions, are called interstitial cells of Cajal. Too sciencey, but what it means is that these cells have the propensity to turn into cancer, but they're not cells of the stomach lining. They're connective tissue within the stomach itself or the gut tract, wherever the GIST arises from. And we treat these with a medicine in a class of drugs called tyrosine kinase inhibitors, or TKIs. And in our world, the word prevalence means the number of patients that have the disease at one time, and the incidence is the number of people that are diagnosed in a year. So with GIST, the prevalence, meaning people living with GIST, is now, after years of research and years of new treatments, outgrowing the number of people that are getting diagnosed each year. And that's because these treatments are very effective. These TKIs work really well. So people are living way longer than they were before the invention of these TKIs and the use of them for GIST patients. It's rare for GIST to be diagnosed in patients under 40. The average age is between 40 and 60 years old, and men and women, male and female here on the slide, have equal predominance. Unfortunately, they do have a high propensity to have metastatic disease, usually in the abdomen. So on this slide, I'm showing you a picture of the liver. That's the organ called the liver there. And in the three different icons, you're seeing the top one called oligometastatic disease, where there's just one tumor in one organ outside of where the tumor started from. In the second picture, we're seeing multiple different tumors in one organ. And in the third picture, we see the inside of this gentleman's stomach or abdominal cavity, plus other tumors somewhere else. And so surgery, if you have local disease in one spot, surgery is the mainstay treatment and is curative, actually, in up to 60% of patients. When we have locally advanced disease or metastatic GIST, metastatic meaning it starts in one place, moves somewhere else, the treatment is either systemic treatment with medication plus local therapy. I write local therapy here, meaning we can radiate or do something called an ablation in this area, or chemoembolization. Those are treatments done by different doctors than myself, interventional radiologists, but these are different options we have. Systemic therapy, pills, plus local therapy, some sort of direct targeted intervention on a metastatic site. Now, I know this slide is overwhelming and a bit sciencey, but I just wanted to list to you guys the importance of why we're going to talk about these mutations. And so here on this side, I think you can see my arrow, I hope, but maybe you can't. But this is a cell membrane. So if we look at one cell, this is the outside of the cell at the top. And on
we can't see the mouse. Oh,
How about
now we
now?
see it.
Oh,
Now we're
perfect.
seeing it.
So this is a cell membrane. On the inside of the cell, we have this area of these little guys are called receptors. So this receptor sticks all the way through the membrane, and there's the external part or the internal part, or the extracellular, meaning outside the cell, and intracellular domains. Now, why I'm showing you guys this is because it's important that within this receptor, let's use an analogy about, I think it's easier to say that on this receptor, there's many different genes, okay? Each of these genes, we can call those a different city. KIT being one city or a gene within this receptor. And then the street address for where a mutation can pop up is called exon 11 or exon 9. So in the region of the KIT gene, which lives in this receptor, there's multiple different sites at where a mutation can arise. And that mutation is what causes the constant activation of these receptors so that they turn into and grow into tumors. The cells at a cellular level are stuck in the on position, and they grow and grow and grow. And that's because of a mutation in 70 to 80% of patients at the gene called KIT, 5 to 10% of patients in a gene called PDGFR. And in patients that have neither mutation in KIT or PDGFR, we call that the wild type of GIST. So 10 to 15% of patients have neither a KIT or a PDGFR mutation in their tumor, but we see something called a RAF or a RAS or an SDH or an NTRK mutation, among others. And so it was important. I just wanted to show you why and how we're getting these fancy names and letters. It's alphabet soup, to be honest. But the important thing is to know that there are certain drugs that target these mutations, which are the reason why the GIST arises in the first place. So this table is a nice summary, and it tells us on the left side of the slide in this table here, we're seeing people that have a GIST tumor with a mutation at KIT exon 9, exon 11, everything in this left column. Those are what we call imatinib sensitive mutations, meaning we treat the patient with a drug called imatinib, one of those tyrosine kinase inhibitors, and there's a high likelihood or a really good chance that the tumor is going to respond and shrink and melt and go away. On the right-hand side, there are these mutations called KIT exon 13 and 17, different than the primary mutation. These patients are what we call secondary imatinib resistance mutations. And I'll try to explain that a little bit in that the patient is getting imatinib. They're treated in the first line setting with the drug called imatinib. And over time, the tumors get worse. We know a subset of patients develop these mutations called KIT exon 13 and 17 as secondary resistance mutations, meaning the imatinib will no longer work. And these patients have developed resistance to imatinib by way of the development of these mutations in KIT exon 13 and 17. Here in the middle, these are different mutations that don't respond well to imatinib from the outright. So they are diagnosed with GIST, and we send off the tumor for molecular markers, and we find that they have, say, a PDGFR mutation here in this particular exon. That's the street address of this particular mutation. We have a RAF mutation. These don't necessarily respond to imatinib like the exon 9 and exon 11 patients. So why I'm mentioning that is because it's important in our world that we get these molecular tests right away, or in the first couple of weeks that a patient is diagnosed with GIST, because you can see here that the treatment is different. So for somebody with an exon 11 mutation, we treat them with 400 milligrams of imatinib, which is also called Gleevec. So I'm using those terms interchangeably. Gleevec is the brand name and imatinib is the generic. So we have Gleevec or imatinib being treated at a dose of 400 milligrams for patients with exon 11. But patients with exon 9 actually have a better response when the dose of imatinib is higher, 800 milligrams, 2 times the dose of an exon 11 patient. But you see here that there's other drugs, avapritinib, sunitinib, RAF inhibitors, not tyrosine kinase inhibitors, but RAF inhibitors that work when the molecule that's altered is different than those imatinib sensitive mutations I discussed before. And the only reason I'm showing you this is because I wanted to make it clear that it's important that we understand the landscape of the GIST tumor so that we can identify these actionable mutations with the right therapeutic target. So for example, a RAF mutant GIST shouldn't necessarily be treated with a KIT inhibitor or imatinib, because we know from lots of studies and data that they won't work as well. And here's just two of the studies I wanted to show you in as basic as I can explain it. There was a study in 2006 in the European Journal of Cancer, and it looked at patients that had one of these exon 9 mutations and an exon 11 mutation. And look at I bolded it here, the exon 9 patients had what we call a median progression-free survival. That means the amount of time that the patients are living without the tumors getting worse. And at a dose of 800 milligrams of imatinib compared to 400, that time is about over a year longer, 16 months longer, when you give the 800 milligram dose compared to if you take the 400 milligram dose. On the bottom here, this is a graph, which I think is one of my favorite kinds of graphs because it's simple for me to see. The lower the amount of lines go, that means the amount of patients that have a response, meaning their tumor gets smaller. This is called a waterfall plot, and I really like the waterfall plots because they're easy to understand. So if we take this line where it says 0, that's the time that the patient starts the medicine. And each of these bars is one patient. So you can see from this Navigator trial in 2020, this looked at the drug avapritinib in patients with that mutation at the PDGFR alpha exon. And over 95% of the patients that took this drug had some sort of response. The tumor shrunk in some way when they were taking that medication. Now, those were the primary mutations, but what I want to focus on is secondary mutations, the mutations that develop and cause resistance to imatinib, meaning the patient was taking imatinib from the beginning, and over time, we're seeing on their CAT scans or they're clinically feeling worse, the tumors are growing or changing in a way that we call it progressive disease. On the left-hand side of the screen, you see all the different, these street addresses, I keep calling them, the exon numbers within the KIT gene. And these are different resistance mutations that can arise. And on the right, we're seeing all the different drugs that have been studied. Now, this table comes from a 2019 study by Dr. Serrano in Spain, and it was looking at all the different, either FDA approved or not, drugs, tyrosine kinase inhibitors, imatinib, sunitinib, regorafenib, and so on. And it looked at these drugs' ability to treat patients that had these mutations on the left, these resistant mutations. So a red dot means, and I always say this every time I give the talk, I'm actually colorblind, but I've memorized after giving this and studying this for so long. I know the red dot, the blue dot, and the yellow dot, and where they are. But to me, this is just, this is a wild sight to see. But the imatinib, all the dots are red, and red means that the drug will not work if you have this mutation. We know that there is a resistance. So for someone that has an exon 13 mutation, imatinib won't work, regorafenib won't work, sorafenib won't work, and so on. A blue dot means that it will, that it is sensitive, and the tumor with this mutation may show signs of improvement if given the drugs in blue. And so the point here that I'm trying to show is that not one of these drugs works wholeheartedly with every single mutation. And so in the absence of approved drugs that have what we call pan-KIT inhibitory activity, or a drug that works at every mutational level, we don't have a drug that works at every mutation site. And so that's why we're working really hard to find novel therapies or newer drugs in order to overcome these changes, these resistance mutations that develop over time. So this is a patient that actually had a KIT exon 11 mutation in the beginning and was treated with imatinib, but developed one of these exon 17 resistance mutations. So at the top here, I'm showing you on the left is a CAT scan, and on the right is a PET scan. CAT scans look at the mostly size and the morphology or the way the tumor looks, and the brightness on the PET scan here is what we look at. So this patient had a 4.5 centimeter tumor. The top of the slide is the patient's stomach, and the bottom is the patient's back. So there was an abdominal wall GIST, about 4.5 centimeters, and the SUV is basically just a number that tells us, just a number that tells us how bright it is. So this SUV was 9. This patient had one of these exon 17 resistance mutations. So if we look at this slide, exon 17, we know will have some sort of blue dot, meaning some sensitivity to this drug called regorafenib. So that's what this patient got. And after 4 cycles, about 4 months of treatment, the tumor size shrunk from 4.5 to 3.0, but the other dimension in this direction was about half of the width that it was before. And more importantly, the SUV that went from 9.9, that glowing hot number, went to less than 3. So this on the left is what we call a radiographic. This on the right is what we call a metabolic response in a patient who had an exon 11, but also developed an exon 17 resistance mutation. Now, the question becomes, how do we detect these mutations? And often we're doing studies on the tumor itself, the tissue, whether it was from a biopsy or from a surgery. We're slicing up that tumor, looking at it under a microscope, staining it with different dye, and we're looking to see if those mutations exist. And this patient on tissue was found to have an exon 17 mutation. Now, everything that I just went through these last 15 minutes about all of these studies that we know about why primary mutation GIST, it's the importance of knowing these mutational differences to give them the right treatment, to make sure that we're picking the right therapy for the patient with these mutations. What's really disheartening and really discouraging is that despite what we know, this slide is showing us a study done in 2020 that reviewed all patients in the whole United States from 2010 to 2015, 5 years of data that showed more than 70% of patients, or if we phrase it a different way, less than 30% of patients actually have their tumors tested for these mutational analyses. So there are 70% of the GIST population in 2010 to 2015 of patients walking around that are either being treated with X drug, maybe it's imatinib, maybe it's nothing, but their tumors were never sent for mutation testing from the beginning. And that's disheartening and discouraging for us, and why we do split webinars like this, and why our teams try to get the message across to other providers and to other areas about why it's so important to get mutation testing. And I think the LifeRef group does an excellent job in promoting that and helping patients who have access that's limited to other places. And so we talked about tissue biopsies, right? But what I want to focus on now and change gears a little bit is something called a liquid biopsy. And this is a regular blood test, just like if you were to go to your doctor's office and get what we call your CBC or your CMP, your metabolic panel, looking at your electrolytes, your kidney function, the hemoglobin, the platelet count, a blood draw. This test does the same thing, that it just simply takes a sample of blood and is a very quick and non-invasive way of looking for these particular mutations. We know from other cancers, lung cancer, to look at, to diagnose sometimes, or to treat different types of lung cancer. Colon cancer, we can pick up what we call residual disease, tumor mutations later on in the course of someone with colon cancer. We use ctDNA or liquid biopsies often in those cancers, so why not transition this practice to more in our sarcoma world, in the GIST world? And so in 2020, there actually was a study here at Sylvester, the University of Miami, looking at patients that had GIST and whether or not we can do this circulating tumor DNA test. And is it as correlative, or is there a concordance between what we know works, the tissue biopsies or the tissue specimens, and the ctDNA sample? Are we seeing the same mutations in the blood that we're seeing in the tissue? And interestingly, here we had 36 patients that had tissue. The darker orange are the patients that had tissue mutation tests, and the lighter orange are the patients that had circulating tumor DNA samples evaluated in our center. And so what we see here, this is just one example. In the KIT exon 11 area, there were 25 patients with tissue confirming that these patients with GIST had an exon 11 mutation. Of those, there were 17 patients that had the same exact mutation found in their blood compared to the 25 that had it in their in the tissue. And another way to look at this on this slide is here, we have 36 patients that had, this is the tissue, the tumor had a mutation. Overall, we had 22 patients that found the same mutation in their blood. So the detection rate doesn't look that great, 61%, but if we look at the number of patients on the bottom, those that had what we call metastatic disease, large volume disease, or progressive disease, and we defined large volume to mean that the tumors combined are greater than 10 centimeters, or the number of tumors is more than 3. If patients met that criteria, meaning they have advanced or unresectable, not able to be operated on, metastatic disease, 100% of them, every single patient that met this criteria, had a liquid biopsy that showed the same exact mutations that their tissues did. And that's really important because, one, I said it's more rapid, it's quicker analysis, and it's far less invasive. So this study showed us that NGS that's called next generation sequencing, just a fancy way of saying mutational analysis from ctDNA is a useful and non-invasive method for GIST patients, sure. Yes, there are these limitations that there's low sensitivity in the patients that didn't have a lot of tumors and a lot of metastatic disease or smaller tumors, but it was really well correlated with patients with higher volume disease. So I guess as a proof of principle, I wanted to quickly look at a patient that we had here, a 55-year-old gentleman with metastatic GIST from the stomach to the liver, and he had progressive disease with 5 different tyrosine kinase inhibitors. Started with imatinib, he got sutent, regorafenib, pazopanib, or Votrient, and nilotinib. And in fact, he was enrolled in hospice and had a ctDNA liquid biopsy. And on that ctDNA, this is how it looks for us. So when a doctor orders this test, what we see is what they show us as the mutations that come up in the blood. And this guy had a mutation at this site called Y823D, which is at the exon 17 position. So this map is another version of that other multicolor thing that drives me crazy, but sorry that this looks a little bit off. But the green in this one is this is sensitive. So this patient had an exon 17 mutation, so he could get treatment with regorafenib, which he already had, or ponatinib, avapritinib, ripretinib, and they would theoretically work for this guy. So he was started on ponatinib. But before he started, this is his liver. This is a CAT scan. His liver has this big tumor here. After 6 months on ponatinib, it looks like this, much smaller. And then after a year, same thing. So this guy has a very durable or a very long response to the ponatinib he was getting, which was selected for him based on his ctDNA. So I mentioned before, there were 2 different studies that were presented at ASCO this year. The first one by Dr. Trent and I, and the second one by Dr. Serrano and Dr. George. And the first one, we'll talk briefly about these, and then we'll have time for questions at the end. Just a couple more slides. I hope everybody's still awake. I'm not boring you too much yet. Usually I throw pictures of my son or dog into these slides to keep everybody on their toes, but I guess I lack both a chocolate lab and an adorable 2-year-old. But in this study, we had 104 patients at our center with GIST that had ctDNA samples sent and analyzed. This diagram is called a chord diagram, okay? And a chord diagram shows 1 line per patient. So all around the outside here, we're seeing all the different genes or biomarkers that we picked up from the blood. There were 57 different genes or biomarkers detected. And you see this one patient here had a mutation at what we call TP53. And this patient had also, if we follow this line, had a mutation at KIT. But basically all these lines represent one patient. So we can see that there's lots of different mutations that we can pick up. And what we do for these patients, we're still studying. The most common alterations, of course, was at the KIT gene. About 64 patients had a KIT mutation, and all these other ones were also pretty popular and prominent, and we picked that up again from the ctDNA blood tests. So if we look at the top 4 most common driver genes, the ones that cause those receptors from way back in the beginning of the talk, those receptors get stuck in the on position because of a mutation at one of these gene levels. So KIT, NF1, PDGFR, and BRAF are 4 of the most common. And in our study, we had 83 patients that had at least one of these. 64 of them had a KIT mutation. And so when we're talking about KIT mutations, we talked before about the primary mutations that cause the cancer in the beginning, exon 9 and exon 11 here. But in these gray boxes, I'm showing you the ones that have developed secondary or resistance mutations after they were treated with imatinib in the beginning. So there's mutations at KIT exon 13 and 17 that we focused on. And we looked at those groups of patients, the ones with a KIT exon 13 imatinib resistance or secondary resistance mutation. Same thing with the group of patients that have a KIT exon 17 imatinib resistance or secondary resistance mutation, picked up again from the ctDNA. And in our patients, there were 25 that had an exon 13 mutation. And the majority of these patients were white, non-Hispanic men with primary tumors in the stomach, called a gastric GIST. And the demographics for the exon 17 patients were the same, predominantly white, non-Hispanic men with gastric primary GIST. And so when we looked at the outcomes data, basically studying these patients and what medicines they got retrospectively, meaning this study was done on patients that already got treated. We were just analyzing the data of the ones that got treated with X, Y, or Z. And so what we found was, again, that ctDNA is a non-invasive tool because it can detect both the driver or the primary mutation and the resistance mutations. And interestingly, in our 25 patients that had one of those exon 13 resistance mutations, they lived longer without having the disease progress when they were given a drug called sunitinib. So if a patient has a ctDNA detected KIT exon 13 mutation, sunitinib in our study was a better drug of choice for these patients because they lived twice as long as patients with other drugs. We also looked at a drug called regorafenib, and that drug didn't actually show any superiority compared to the other tyrosine kinase inhibitors if there was an exon 17 resistance mutation from the ctDNA. And all this mumbo jumbo talk and jargon here is basically to say that we're trying to look at whether or not ctDNA is a good biomarker or gives us a good enough analysis of the biomarkers that the patients have to warrant evaluation in what we call a prospective clinical trial, meaning we detect the mutation first and then pick a particular treatment to give the patients, sunitinib or regorafenib. And that's what we're working on at our center. It's not yet open, but it's a clinical trial that will be open, and it will use the blood biopsies, the ctDNA, to stratify or to assign a patient to one therapy or another. And our plan is to look at these patients for 2 months at a time, 2 cycles at a time, 56 days, 28 days is 1 cycle, 2 cycles, 56. Do some more scans and see how the drugs are working in these patients with these particular mutations. The second one, I'll be brief here. This is another study of ctDNA that Dr. Serrano presented at ASCO. And this one took patients that had advanced GIST and already had 1 or 2 treatments. And so now they were in their 3rd or 4th line therapy, the 3rd and 4th drug after getting already imatinib and sunitinib. And 240 of these patients were given avapritinib, and 236 patients were given regorafenib. This is a study called the VOYAGER Trial. And in this study, what it showed, it actually was the first phase 3 international study in advanced GIST patients looking at the utility of circulating tumor DNA. And what it showed, it's a little bit hard to understand and a little complex with the words and the language here, but what we saw from this study is that patients lived longer without the disease getting worse if they were treated with regorafenib and had an exon 13 mutation. If they had been treated with regorafenib and had an exon 17 mutation, or they were treated with avapritinib and had no ctDNA detection of an exon 13 mutation. So the take-home message is that this KIT exon 13 mutation is important because with or without it, the treatments are different and the outcomes are different from this small study that we have here. But again, this all hammers home the point that I'm trying to make in this last half hour, that ctDNA sequencing is really important in patients with GIST because we can come up with different treatment plans based on the blood biopsy, detecting these mutations or not. And so this is a shameless plug at our TEAMSARCOMA at the University of Miami in Sylvester. And I'm so grateful to be a part of it, but more grateful for people like you guys. And I know what it's like for everybody out there going through the long treatment course with an underlying cancer and sarcoma in general. So I commend you guys, 1, for hopping onto this call, but 2, people like Ms. Stevens on the call and everybody else who takes care of patients with GIST. A big round of applause to you guys too, because we know that this is a hard process, but we're doing everything we can on our end as scientists and physicians to provide that hope. And there's a lot of it going forward, and we're working hard to find these new treatments for you guys. So, Sarah, that's all I had,
Yes.
and I don't know.
No, it was a great presentation, and I think it shows a lot of utility, even globally. You were saying in terms of doing a blood draw might help with access to this type of testing where they might not be able to afford doing that type of testing internationally with the paraffin tissue. So a lot of possibilities, and it's great to see the work that you are doing at Sylvester to help raise awareness about this type of testing, both
Sure.
at medical conferences and these patient education seminars. I'd like to transition to Stacey. We are so pleased to have Stacey here today. We met her at our patient conference called Life Fest in July. I think she really inspired people when she got up and asked some questions to the doctors. And I think she has her own perspective and story to share with the community today. So I'm going to have Stacey go ahead and share her story. Go ahead, Stacey.
Take myself off mute. I'm sorry. Hi, good morning. My name is Stacey. My husband, Faith Irving, was diagnosed with GIST back in, well, not back in this February. And not only were we told that he had cancer, but that we had GIST cancer, a certain type of cancer. And we were told just to, start taking Gleevec and see you in 3 months. And, he wasn't a candidate for surgery because he had stage 4 and it spread to the liver, but his primary tumor is on his small intestine. And it was like a size 8 centimeters. So went home, took GIST, waited for the medicine. And during that time, I started, looking up different things about GIST, and I came across the Life RAF group. And everything I read was GIST specialist and mutational, GIST specialist and get mutational testing. So that was my goal. And I was blessed to find a GIST specialist at MD Anderson. And we went there, and not even knowing that they did the circulating, the basic mutation with the tumor, and it also did the mutational testing withdrawing his blood, and which was a good thing because it was done at the beginning, without having any knowledge about mutation, what was the purpose of it, why to have it. And then once I learned that certain subtypes respond to certain medications, so we were blessed at the beginning to get this test done. And that prevented us from having to go through the possibility of his tumor getting larger, not responding, having resistance to the treatment, avoiding any ineffective treatment. And so during that time, we did find out that he did have the most common type, which was exon 11, because so kind of was the luck of the draw, because, we put on the right medications, but not even being told during that initial visit, anything that this is such a whole world of GIST. So, it's not just GIST, but all the families, and I call them the cousins and the nieces and the nephews, and they all respond differently. So we were blessed to be able to get this type of test, and not even knowing and then having a GIST specialist to know that we are responding, and his tumors did start reducing. And I just think it's important that everybody, at the beginning, we all become GIST specialists at some point, and knowing, to request for this. I just was, was able to, when I got a GIST specialist, that's what she did, and request, what type of mutational test. I just say, what's his mutation, and she did that for us. But I was just thankful that we were able to get this, and I just pray that that this becomes more popular, and that more people take the initiative to request testing for the mutation, because it is important to know it, because it's a very long process, and it's a very kind of up and down process for us. But that's pretty much what our experience was. And
Amazing. Stacey, thank you so much. For somebody who's so new in their journey, I think she took home 2 points that we like to emphasize to anybody who comes to the Life RAF group. It's number 1, it's important to see a specialist. And number 2, make sure you get mutational testing. And I think you demonstrated that very clearly. And I think it helps empower you with a lot more information to help support your husband with his diagnosis and treatment plan. So thank you so much for sharing that. And I hope that inspires other people who are listening today, or even the recording, because it's very important for people to be informed about what type of GIST that you have, and make sure you ask these questions to your doctor.
Absolutely. And just to piggyback off that, I think you nailed 2 of the things that Stacey did really well. And the number 3 I would add is, it's so important, and you're doing a fantastic job at it, as being an advocate for your husband. And advocacy for our patients is major. It's huge. And have a support network as good as your husband's with you and the cousins and everybody else that you say It's a huge family it's a small family in the sarcoma world compared to, I know I keep mentioning the breast cancer and the lung cancer, and certainly any type of cancer is just as scary and apprehensive of a diagnosis. But to go through this in the sarcoma world where it's so rare, it's such a small community, and people like you are the ones that bring the most for the patients. So we thank you, and you're doing a great job.
Thank you.
Absolutely. And I'd like to just jump into the Q&A portion. You know, and I think Stacey and many others, they receive this report with their doctor and they go through it. But like you were saying, there's a lot of letters and acronyms that can be so confusing and hard to understand these reports. When somebody gets a report that shows the different mutations, how do you decipher what's really driving the disease? Because sometimes it may say exon 11 and exon 9 or others in certain percentages next to it. So how does a doctor know how to then proceed with different mutations being listed in that report? And what can a patient do to ask those type of questions?
That's a great question. And we do get asked that a lot, especially if we look at the ctDNA side of it. Those percentages that are reported, usually that number represents what we call the variant allele frequency. Again, another scientific term that just means how many times we're seeing that mutation in that gene in the sample that they have. And so I showed you that chord diagram that showed that there were many patients that had multiple different mutations. And, you know, to kind of go at your question about which one is the driver, how do we know? And usually it's the one that has the highest variant allele percentage. But there is, you know, some patients that have such low level or low volume ctDNA to begin with that the mutation status, it's hard for us to know which is the active mutation. And it's not necessarily you have it or you don't, it's an on or off thing, but it's a lot of different factors go into the decision of what is the best treatment for this patient and what is the next treatment for this patient. But having that foundation of in the back of our head as physicians and as treating doctors, we know there's a mutation there is a potential target. It's not a one and done thing. We sometimes serially test ctDNA multiple times through the course of the disease, again, because these tumors have such high propensity to change their biologic nature. So in some patients that have, let's say, a stomach GIST and then metastatic disease to the liver later on, and then a metastatic tumor in the intra-abdominal area, theoretically, we could biopsy all three of those tumors and look for mutations, and they may have different mutations in each one. The liver tumor may have different mutations than the abdominal tumor. And so that's why we're big proponents of the blood. The blood shows us everything, mutations that are circulating the body all over the place. And so if there's circulating tumor DNA showing one of these mutations, the hope going forward is that this will help us pinpoint which is the right targeted medicine for this mutation that the patient has in the bloodstream. I don't know if I'm going off on a tangent or if that answers the question, but the bottom line is there's a lot of different factors that go into treatment, and we like to use all the tools we have in our belt. And one of them is, you know, this mutational analysis that I think is huge.
I think your future study that you alluded to will also be very helpful to understand like how that factors in terms of what
Definitely
can be helpful towards treating it based on the blood results.
Of course. And that's why we're trying to cater the ctDNA results to the particular treatment to see, is this something we really can truly use as a biomarker for determining, you know, the treatment selection.
Yeah. So a couple people reached out regarding SDH deficient GIST. They wanted to know like if there's any data regarding this type of diagnostics with the disease. Now, I know it helps with circulating that there's a high tumor volume, but sometimes people with SDH deficient GIST have multiple tumors. So you know,
Sure.
one of the questions was like, if they have these inoperable tumors that are in, you know, in their system, if there are tumors in the blood, won't they always come back? Like, how do you, and there's also there's a question in terms of the disease. Sometimes people argue it's more indolent than not. So it gets a
Sure.
little bit tricky with that, if you have any thoughts.
Of course. And so to go based off the question, I think that someone had here about tumors in the blood, what we're looking at the blood for is the mutation. So we're looking for those mutations in the bloodstream that may or may not make up or cause the GIST to be active. And so when we see somebody that has an SDH deficient GIST, the entire biology is completely different than someone who has a KIT or a PDGFR mutational GIST. And the treatment, therefore, is very different. So I listed on the slide the different types of treatment for, say, a RAF mutant GIST compared to a KIT exon 11 mutant GIST. But with SDH deficiency, the data is not, it's very sparse, and we don't have much. And there's only 10% of patients in that category of what I told you was the KIT or PDGFR wild type. An SDH deficient GIST falls into that category of one of those wild type like GISTs. And usually the treatment is surgery, but these TKIs don't necessarily work as well for SDH deficient GIST. And some patients can have more dormant disease, like you said, Sarah, where they're not as active. There may be tumors in multiple spots, but those tumors aren't necessarily affecting organ function or causing clinical symptoms of pain or nausea or things like that. And so, sure, surveillance or monitoring to make sure that it doesn't affect organ function is really important in all sarcomas, really. But with these SDH deficient GISTs, where we know the treatment options are limited, more so than an exon 9 or exon 11.
Yeah. Okay. Very good. Thank you. There was a question about can ctDNA be predictive for GIST patients that are currently having no evidence of disease? This person had a large exon 11 tumor removed many years ago, over a decade ago. So can it predict?
That's a great question. And I would love if the answer was yes, an easy yes. Unfortunately, from what we know from our study in 2020, the patients that had low volume disease or very minimal disease, like the patient who just asked about having a decade of low volume tumor, can we detect whether there will be or will have the propensity to have recurrence later on? Right now, we don't know the answer to that, but what we do know is that patients that have low level disease or very small tumors, the ctDNA in the GIST world is not the best. It's not as helpful as we'd like it to be. It's really concordant and really good if you have a lot of tumor and a lot of disease. But for those patients where we're looking to see if we can pick up a mutation and say, in 5 years, your tumor is going to come back, that answer we don't know. In other tumor types like colon cancer, we use ctDNA to see if there are circulating colon cancer cells in the blood. And there have been studies that show if the ctDNA is positive, even though the CAT scans are negative, there's a higher chance that those patients, again, colon cancer, will have their tumors coming back. And we can treat them as such sooner than we would than when we see it on the imaging. But for GIST, we just don't have those answers yet.
I guess that also goes in line with somebody who asked about using it for early detection of GIST, which is really what you're just saying. But it makes me think of like the EGIST that there's this concept out there that people have these EGISTs. And so I didn't know if like that was so microscopic that's probably also very hard to detect.
Exactly. I think it's all about the size of it. It's, it's the volume and the burden of disease.
Okay. Well, somebody asked a great question. This is something the LifeRef group asks all the time, and is what do we need to do to make mutational testing a basic standard?
That is $1 million question. And if I have the answer to it, then I don't know what would happen, but I would love for it to be basic standard. We try so hard. We do. And in our center, we make it standard. I don't know if it's a insurance thing or if it's an access thing or if it's people don't know enough about GIST because they're so rare. Sarcomas treated in the community are very hard treatments and very hard diagnoses. I told you that a lot of pathologists, even sarcoma pathologists, don't agree on what the tumor is. And so to make it standard, it's people like you guys, people joining this webinar, people like me, people who are involved in sarcoma research. We just need to yell louder than the next guy and make sure that people are understanding that we have something here. And we know that these mutational tests are super important and are very helpful in guiding treatment. And the outcomes are better when we know the mutations and can put you on the right drug. So I just, encourage everybody to keep singing and keep.
Yes. Everybody who listens today needs to do their part. I know people have their own situation that they're working with in terms of their disease or a loved one, but there are guidelines, but not all doctors reach and look at those guidelines to know that this should be built into their clinical practice. But if you do see a community doctor, or if you're just expert that you do see interacts with community doctors, make sure that they share that message loud and clear, because then we can get those percentages up from, some of those publications that Dr. Bialick quoted, where we're going to get a lot more patients getting this testing done, which is really important in terms of their outcome.
That study that I showed you, actually, that was from 2010 to 2015. So I'm now really interested because I've given this talk so many times, and I still am. So it irks me every time I get to this slide. I'm like, look at these numbers. That was 7 years ago now. It's crazy. Someone was just saying before, like, can you believe the 90s were 30 years ago, which makes me feel terribly old. I can't. But this study was 7 years ago. So if we update it, maybe there will be some more increased numbers than the less than 30%, but still not where we need to be.
Right. And another shameless plug, the Life Ref group does have a testing initiative. So anybody who might be listening, finding this through the internet, if you reach out to the Life Ref group, liferefgroup.org, we can tell you about this testing initiative. And at this moment, it is free to get this type of testing done, where we partnered with a lab called Tempus to get a multi-gene panel tested with your tissue. So I don't see any other questions that have come in. So I think we covered some really important points today. I want to thank Dr. Bialick. It's always a pleasure to have you. I think you very much are in sync with our passion to share the message, the gospel of getting this testing done across the community. So thank you. It's always very clear and understandable. We appreciate that. And I also want to thank Stacey for sharing her story with her husband, Fate. I think it really helps to hear a real life example of somebody navigating this disease and what questions and advocacy that they've done to get to the point they are today. And Stacey, it was a really wonderful opportunity to have you speak with the community. So thank you for that as well.
Thank you guys so much. I appreciate it and commend you again for joining. And I really appreciate the callback, Sarah. I'm happy to be
here. We love working with you, Dr. Bialick. So I think it was a great presentation today. Thank you so much, everybody. This is going to be recorded and posted soon on our YouTube channel, so look out for that. And with that, everybody have a lovely day. Enjoy. Bye.